Welcome back to one of the last block contents in the basics of pharmacology. We're going to spend a few minutes talking about medication safety. In 1999, this was about 3 years after a serious chemotherapy medication error at Dana-Farber Hospital in Boston, a report from the Institute of Medicine was published and was quite landmark in that it quantified the estimated deaths per year related to medical errors, estimating somewhere between 44 and 98,000 deaths per year happen just in hospitals due to medication or medical errors, not just medication errors. They predicted at least 7,000 deaths of those 44 to 98,000 deaths were because of medication errors. Since that time, and actually even before that report was done, there was an organization called the Institute for Safe Medication Practices that's been around since the 1970s. It's a nonprofit organization that really tries to look toward making recommendations and giving health systems and healthcare professionals guidance on ways we can make healthcare delivery, particularly as it relates to medications, safer. I encourage you to go to the ISMP website. It's ismp.org. Look around at the kind of things that they have. They have a number of guides, tools, and other recommendations based on the kind of problems that can happen in healthcare. In practice, there are anywhere from 5 to 7 to even sometimes considered 10 rights in medication ordering and administering. So the classic 5 rights that have been around for decades are making sure that we have the right patient, the right medication, the right dose, the right route of administration, and the right time. To that, in the last decade or so, 2 more have been added, the right documentation and also the right reason. We'll talk about all 7 of these. There are also 3 additional, sometimes, rights to medication use and medication administration. Those include the right for the patient to refuse their medicine, making sure we have the right assessment of the patient before we start the medication, and the right evaluation of their response to the medication. Let's look first at making sure we have the right patient. This is surprisingly common, even though you would think it would not be. It can be common in any hospital care setting, particularly in a hospital setting if you have the wrong electronic medical record chart open. It's very easy to have more than one chart open at a time, and you can start entering orders on the wrong patient. That happens surprisingly frequently. It also happens to be a problem if you've got multiple casualty situation, family members of the same name, particularly sons and fathers of the same name, also the same last name. It can also be seen with people who aren't related who have in the health system the same last name. So in healthcare, we commonly require something called 2 identifiers. Whenever you're talking about a patient, you typically would use the patient's name, and you might also use their date of birth, their full name and date of birth. You could also use their full name and their medical record number, or some other unique identifier for a patient. We want to make sure we've got the right medications. There are a lot of medicines that look alike and sound alike. Packaging looks alike. The drug names sound alike. Here in this image is ceftazidime versus cefepime, both 2-gram vials made by the same manufacturer. They look very close, and it would be very easy for someone to grab the wrong vial. This is also true with drugs that have dire consequences based on the concentration of the drug. For example, epinephrine comes as a 1 to 1,000 and a 1 to 10,000 solution. If you're intending the 1 to 10,000 solution but grab the 1 to 1,000 solution, you just grabbed a 10 times higher concentration of epinephrine. There are many other medicines that look alike, sound alike. You'd always want to make sure that when you're looking at medication, both ordering and or grabbing a medication to administer, you always read the label 3 times and verbally confirm the drug aloud, hopefully with someone else who confirms with you, I've got the right drug. Right dose, both in calculating dose and preparing the dose. very commonly in inpatient or acute care settings, we see that the rate of administration of a drip is miscalculated. And the wrong rate or the wrong dose of a drug can clearly be fatal, so we need to be very clear about getting the right dose. We're also concerned about making sure we have the right route of administration. Sometimes a route could be ordered as an incorrect route. Some medicines, IV versus IM, the IM doesn't work as well as the IV does. Sometimes the IV formulation could be fatal on administration when in a certain way that it's administered. So all important that we get the right route of administration. Also important that the medicine is given at the right time, and if it's a stat med intended to be given immediately, that it is given immediately. Timing and sequencing of drugs is critical. We'll talk more about an example is in the management of sepsis. There are what we call sepsis bundles or treatment protocols we use for someone with sepsis, including making sure the sequencing of getting blood cultures and getting hydration and starting the antibiotics are all coordinated very well and very quickly. Also important that we have the right documentation, that things are documented, what we gave, why we gave it, and that it's clear to everybody what that's about. We also want to make sure that in the medical record, the documentation for the rationale for what we're doing, particularly if it's controversial, is done. Consider, as we discussed earlier, the importance of getting informed consent for controversial therapies. And in some cases, particularly biologics like vaccines, we need to make sure that lot numbers for the products are also recorded in the medical record. It's also important to have the right reason for why we're giving a drug. So many times clinicians will consider when they're writing a prescription or they're writing orders to specify the indication for that order as they're ordering it, so that it's a double check for everybody who's giving it that the right reason is apparent. You also want to make sure that if it also gives the person who's filling the order, the pharmacist who's filling the order, and the nurse who might be administering the order, hopefully they're engaged when they're in their process of evaluating the order and administering the drug, and that there's a rationale for it. So important that folks are engaged and critically thinking the entire time they're working and taking care of patients. We've already talked a bit about adverse drug reactions earlier on, and that can overlap with preventable adverse events. Preventable adverse events, as you can well imagine, are bad things that happen that we could have prevented. Sometimes they result in harm, sometimes they don't. If an a preventable adverse event involves no harm, then we have a big sigh and say, thank God. But these preventable events can also be associated with harm. There are a number of abbreviations that are dangerous to use, particularly because they can be confused for other interpretations. We try to avoid certain abbreviations, QD, QOD, OD, which are old Latin terms that have been historically used. We avoid using the abbreviation U for units because it can be read as a zero. We are careful about how we write or use symbols and or other abbreviations. The ISMP has a list of error-prone abbreviations, and you can see the beginning of this list here. I encourage you to go to the ISMP website and look at some of the common list of abbreviations that are listed there. There are also, the ISMP has a list of oral meds that shouldn't be crushed or broken. These are tablet or capsule delivery systems or other delivery systems that if you break the integrity of the tablet or capsule, the entire contents that are intended to be administered slowly, absorbed slowly over hours, get absorbed all at once, and the patient could have a toxic reaction. Most healthcare settings have a look-alike, sound-alike list, but they also have a high alert medication list. And these are medications that are known to be problem-prone. They typically will include things like opioids, insulin. They might also include anticoagulants, and chemotherapy. So those are medicines that are prone to be higher risk medications in acute care settings, and hospitals have such lists to keep people aware, hey, these are the ones we really have to be particularly careful about. Also, the look-alike, sound-alike, or confusing drug names. There are many drug names that sound like other drug names, and so important to not confuse those. Many times in most automated healthcare systems and electronic medical records, they'll utilize something called tall man lettering, where you will see most of the drug name is in lowercase, but then they will have in uppercase letters a portion of the name of the drug to differentiate that from another drug that has similar look or sound to it, so that it's less likely to be confused. There's also this concept of a principle of just culture, and this has become common in most healthcare settings these days. And what it is a way to set up a means to be transparent around risk and to be fair and appropriate and reduce risk for patients, while recognizing that most errors that happen in healthcare systems are related to system problems, not related to willful errors on the part of employees. So this approach of just culture looks to understand why errors happen and works with staff to redesign systems so errors are less likely to happen. It's not intended generally to be a punitive approach when errors happen, but instead to make an assessment of how we can prevent such an error happening in the future. And finally, the way that we can sort of look at some of these errors that happen in healthcare are to recognize if there's a human error, if there's an at-risk behavior, or if there's reckless behavior. And human error happens when it's not really intended to. It's often a system risk that can have that happen. And then there are at-risk behaviors where folks may have sort of crossed the line a bit and didn't do something that was quite true, but they were extenuating circumstances perhaps that prompted somebody to do something and take a shortcut in a drug administration or ordering or something. Both of those situations, we try to really counsel and coach and console the healthcare provider and how to work on systems to make sure that doesn't happen again. On the far right-hand side, which is pretty unusual, but it does happen, is when healthcare providers just willfully avoid following policy and procedures, and there's an error that can happen because of that. Then that's the sort of the old school approach to when we will look at a punitive action for that healthcare provider. But we really try to look at recognizing most employees, most healthcare providers, thankfully, don't try to do the wrong thing. They try to do the right thing, but it's important to recognize that the policies in place are there to help prevent future errors for patients.